Welcome to ResearchMD.com. My name is Pramil. Cheriyath. I'm a Program Director, Internal Medicine Residency, Transitional Residency in the United States. I'm also Director of Research and Assistant Professor of Medicine, two large medical schools. So we've been doing a series of lectures on endocrinology. So initially we talked about in a nutshell about all these hormones, and then we started on the posterior pituitary. We started with oxytocin, and then we went into ADH and the mechanism of action. Please make sure you watch those presentations. Today, our topic again, diabetes insipidus, a great important topic for examination purpose, and it's very important in all of it. What is the first thing we have to do? We have to define it, diabetes insipidus. Okay. Excretion of copious volume of dilute urine. Okay. And there are two types, inadequate secretion of ADH or impaired renal response to ADH. Okay. So first one is the central. This is what your hypothalamus and the pituitary, and nothing happens over here. It's not working. Okay? And the second one, you got ADH and nephrogenic. This is where our collecting duct, the principal cells, the V2 receptor, that's where the action is. So we need to know central and the nephrogenic causes. Okay? Central, it happens in the pituitary and hypothalamus, and then in the nephrogenic, it happens in the V2 receptors, in the principal, the collecting duct in the principal cells, right? Now, let's look at the epidemiology. The prevalence is in the USA between 300,000, and male-female ratio is pretty much equal. Okay, now let's look at the etiology. We have to look at the central diabetes, what are the causes, and then we talk about the nephrogenic diabetes and what are the causes, okay? And the first one, let's start with the central diabetes, primary, idiopathic, nobody knows, right? And the secondary, a lot of brain tumors, craniopharyngioma, brain mets, brain injury, and subarachnoid hemorrhage, and pituitary bleeding, meningitis, and neurosurgery. Those are the causes, okay, for the central and which is secondary. Now let's look at nephrogenic diabetes insipidus. One thing we have to know, the first thing is there is hereditary. Okay, there's some mutations. Where are the mutations happening? In the V2 channel, in the V2 and the aquaporin. Okay, those are the two places the mutation is happening. Remember that. Now, the acquired is very important. You got like renal causes, chronic kidney disease, polycystic kidney disease, obstructive uropathy, even pyelonephritis, my friend. Yeah, the electrolyte disturbance, hypokalemia, and hypercalcemia. And then when you talk about the drugs, the most important is the lithium, which we'll be talking about later, and demiclocycline, amphotericin B, colchicine, loop diuretic, and all of this can cause acquired. Okay, so those are the causes. Now let's look at our famous diagram up here. How does the ADH work? Right? We have this hypothalamus, it's secreted in the hypothalamus and go through the posterior pituitary. Right, and then kind of release into the principal cells of the collecting duct right here, and this is the V2 of that, and then you got G14 couple receptor, which is GS type. They activate adenyl cyclase, convert ATP into CAMP, protein kinase A, and then aquaporin 2 channel go to the luminal membrane. It opens up, so water get absorbed right here comes in, go into a blood, and then volume goes up. Okay, so you got osmoreceptors pick it up, and then all of this kind of connected with the osmoreceptors to the body. Everybody got that? That is a normal mechanism. Now let's see what happened in diabetes insipidus. Again, two types, right? What happened to the central diabetes and what happened in the nephrogenic diabetes. We have to think a little bit before we just kind of, so I'm going to go a little bit slow up here, okay? So what happens in the ADH release in the central diabetes? Posterior pituitary and hypothalamus, we go to the brain, right? This is not happening over here. That is the central mechanism, okay? So, what happened over here? Nephrogenic, right? It produces there, but it's not working. Resistance in the V2 and the aquaporin channel. So, it's not working. That's the problem. So, ADH is there, but there's resistance. Now, what happened? The mild increase in sodium, okay? So what happens over here? There's no ADH. What happened? Water start losing right here. So your plasma volume, we can concentrate it, right? So what happens? You got mild increase in the sodium. But at the same time, there's a thirst mechanism kick in. When it happens, people start drinking. So it's only like a mild increase in the sodium you will see. Same thing over here because the thirst mechanism kicks in. Everybody know that, right? And then we talk about decreased ADH. Of course, there's no ADH right here. ADH here, when you measure the ADH is normal, right? Because hypothalamus and the pituitary function is there, ADH is going to be there. Only problem is this resistance is not working. So the main difference, okay? Now let's look at the plasma osmolarity again. What happened in the central, this one is not, no ADH right here, right? Urine become boom, just kind of, you lose like a lot of urine. So plasma volume get concentrated, right? So plasma osmolarity will increase. But because of the thirst mechanism, we started drinking, so plasma osmolarity could be normal or increased. Now, what happens over here? The same thing. See, ADH is not functioning. What happened to the urine just kind of passing? Like you lose a lot of urine, plasma get concentrated, plasma osmolarity will increase, but because of the thirst mechanism, it remains normal. Everybody got that? Just have to think a little bit before we just kind of jump into. Now, what happened to the urine osmolarity? Because over here, central diabetes insipidus, right? Urine is going to go down. So what happened to the urine osmolarity? There's a lot of urine, it will go down. There's something called partial and complete. Partial is like sometimes it's working or like a little bit is working. So it's partial and complete. Partial urine osmolarity is between 300 to 500. Complete is less than 300. Okay, so it remains the same for both of the things. Okay, now clinical features, that's very important for us to take a look at it. Polyuria, polydipsia, and nocturia. It's the same thing for nephrogenic and the central diabetes. Okay, so think your way through and find out what's happening to plasma osmolarity, what happened to the urine osmolarity. Those are very important. Okay. Now, how do we get the diagnosis? We got this nice diagram over here. So when you talk about like anytime diabetes insipidus, the first thing we have to do is to differentiate between polydipsia, okay? Psychogenic polydipsia, like or primary polydipsia, those are the things we have to differentiate from, right? So what happens? So you check 3 labs we have to check. We check the plasma sodium, right? You have to check the plasma osmolarity and then you have to check urine osmolarity, which we already talked about, right? So what happened in the primary polydipsia? What happened? The patient drink like tons and drinks gallons of water, right? So then and then what happened to the sodium? Because you get diluted. What happened to the sodium? Because hyponatremia, friends, okay? And then what happened to the plasma osmolarity? Because if they drink a lot of water, plasma also get diluted, plasma osmolarity is going to be low. Now, what happened to urine osmolarity? They also going to pee a lot of like urine. So it's going to be like extremely low urine osmolarity, right? You got less than 250. What is the normal plasma urine osmolarity? Around like 500, okay? So it's going to be extremely low. Remember that, less than 250. So if you have all of this, you can say that pretty much you will say like it's primary polydipsia, right? Now, what happens over here when you have diabetes insipidus? What happens? Mild hypernatremia, right? Because what happened? Our urine is getting lost over here. A lot of urine, the patient is peeing out. So the plasma, you can have like, hypernatremia because it's kind of concentrated. It's only mild because of what? Thirst mechanism kicks in. Remember that, okay? Now next look at the plasma osmolarity, the same thing. You're losing all this water right here. Plasma get concentrated, plasma osmolarity should go up. But sometimes it remains normal because if the thirst mechanism kicks in and we start drinking a lot of water, okay? So, and what happened to the urine osmolarity? It's slow because, you got all this urine because ADH is not working, right? You started pouring in. Urine osmolarity is going to be low, like less than 500, okay? Not too much, not like this, because these people drink like lots and lots of, gallons of water they drink. So we have this diagnosis of diabetes insipidus. Now we got some confirmatory tests we have to do. What are the confirmatory tests? You got like water deprivation test, right? You just don't drink don't give the water for like few hours and then you check the labs again. So if you check all this should come back to normal because this guy, what's his problem? He's drinking like crazy, right? There's nothing wrong with him, but he kept on drinking. That's a problem. So plasma osmolarity become normal, urine osmolarity become normal. So that's, kind of confirmed that's primary polydipsia. Now let's go to the other side. We're still talking about diabetes insipidus, right? What happened to the water deprivation test? Is this going to change anything? No, because there's a problem right there, right? Plasma osmolarity still remains high, urine osmolarity remains low. Just like this, no change because when you do the water deprivation test, right? Now, once we do this, we have to do another test called desmopressin. administration. What is desmopressin? It's an ADH analog, right? So what happened in the central diabetes insipidus? Body is not producing ADH, right? You give ADH, urine osmolality, what's going to happen? It will increase, okay? Because everything is kind of coming back to normal. What happened to the nephrogenic when you give ADH? Is it going to work? Because there's always resistance up here. It's not ADH is the problem because there is resistance happening. Okay, so what happened? Then urine osmolality still remains decreased, so you have nephrogenic diabetes insipidus. Okay, it's very, very important to go through that. But take your time, don't jump in. Find out what exactly body is trying to do to compensate. Okay, and then how do you treat it? If it is central diabetes insipidus, what you do is like you can give desmopressin, right? Because the problem is over here. You got hypothalamus and pituitary. You give, it's not producing ADH. You give desmopressin, everything kind of back to normal, right? It can also cause like hypotension. That's like one of the complications of that. Remember that. Now, nephrogenic diabetes insipidus. There is like first thing is like there's a lot of drugs can cause it. It's an offending drug. You stop it. That's the number one things you have to do. Next thing is give thiazide diuretic, okay? What happens thiazide diuretic? When you give thiazide, you can like sodium get depleted, okay? When sodium, that kind of, when sodium and water get reabsorbed in the proximal collecting tubule. That's the mechanism happening right there. And you can also give NSAID. What does it NSAID do? It incorporates more aquaporin channels into the collective effect right here, okay? So NSAID, which one you usually use? Indomethacin. That's another board question. Always kind of remember that. It's incorporated more aquaporin channels. And finally, you get, let's say in the lithium-induced diabetes insipidus, you give amyloride. What does it do? It inhibits the lithium entry into the sodium channel, okay, in the distal collecting tubule. Remember that, okay? So let's look back and all of this thing, let's one more time. So that's the advantage of like a whiteboard. You can clearly see what are the causes, like where is the abnormality, okay? All of this kind of, you have to differentiate between, the main thing you have to differentiate between primary polydipsia and then all the, and then you have to know it's like water deprivation does what happened when you give desmopressin. Make sure if you know the treatment in nephrogenic NSAID, indomethacin, right? And then amyloride in the lithium-induced diabetes insipidus, we can have questions, you need to answer that, okay? Thank you so much for watching. We'll be back with another presentation. If you could subscribe to our channel, we will greatly, greatly appreciate it because it takes a lot of effort from so many people to make a presentation like this. So please, please help us. Thank you so much. God bless.